record this today. We're very excited to learn more about engaging practitioners in difficult conversations about variation in practice. Before we start today's conversation, I just want to go over a few housekeeping notes. As I mentioned, the meeting will be recorded. We will share it on Workplace. If you're not on Workplace, we can either get you on Workplace, or we're also happy to send you a link to the recording. We're planning on having the lines muted during the while Dr. Beckman speaks, but we will let you unmute once the presentation is done. But we very much encourage you to put questions and comments in the chat. We will be monitoring that, and we can always always have that primed when our question and answer time comes up. And just a reminder that we've started to do webinar evaluations at the very end of the webinar, and it makes a great deal of difference to us to have your input. So we'd love you to fill out the 2-question evaluation that we have at the end. So again, please use the chat. Let us know if you're having any technical difficulties, and we're welcoming you here today. So let me turn it over to Lisa Letourneau to introduce our speaker.
Great, thanks, Kelly. Just wanted to welcome everybody again. Thanks for being with us today. We know it's a rather crazy time out there. We really appreciate everybody's ability to take time out from the current COVID challenge that I'm sure you all are facing in some way, shape, or form. With that, particular thanks to Dr. Howard Beckman, our speaker today. Dr. Beckman is a clinical professor of medicine and family medicine at the University of Rochester's School of Medicine and Dentistry. He's been a faculty member there since 1990, and prior to that was an associate professor of medicine at Wayne State University, where he attended both medical school and completed his residency in internal medicine. Additionally, he's the director of strategic innovation at Common Ground Health, where his work focuses on 2 community-wide quality and value collaboratives. So with that, Dr. Beckman, thank you so much for joining us, and I'll turn it over to you.
Thank you for having me today. I understand everybody's constraints and all the things that are going on in the country and the world, and hope we can stay focused as much as possible on this particular conversation. I've spent the last 20 years or so working in capacities that enabled me to talk to practitioners about variations in care, and have had considerable experience in difficult conversations, which is the topic for today. So I hope to be practical and useful to you in constructing ways of anchoring conversations in a structure that is effective for you. I'd particularly be interested in questions you have at the conclusion of the remark, engaging in some conversation. I'm not sure how most of you are working right now, but the picture on the left-hand side of your screen is how many practitioners feel about their work. It's the obstructed downhill spiral into the jaws of a predator. People are feeling constrained and are often have emotion about their work. So it's not surprising for conversations to end up as difficult. What I hope to help tell you is how you can prevent that as much as possible and build on relationships to create change that is useful to everybody. My objectives for today are to encourage you to build a culture of improvement where specialists and generalists focus on it as a team on outcomes of care, as opposed to the volumes that exist currently. I want to talk a little bit about the stages of change so that you understand why, as a course of action, anchor in the practitioner world is not a bad thing, but something you can use to your advantage. To anchor conversations with practitioners around core values, appropriateness, non-judgmental feedback, and managing emotion. These are the anchors of what we'll be talking about today. motivates human beings, especially physicians and other health practitioners, to be internally motivated so that you're not relying on external motivation for them to change their behavior. You're using their internal motivation, and I'll talk about that at the end of the session. Low-value care is increasingly important to everybody. It's important to payers, and I know they do the analysis in their own world, and for which they are upset that we have not eliminated in our world. Choosing wisely has become an anchor for that process. And as you see on the slide, choosing wisely has begun to encourage patients as well as physicians to ask questions about whether their care is necessary or not. The diagram on the right shows you that low back pain is one of the hallmarks of the low-value care model. I don't know if people think it's important because it's beginning to make a dramatic change in how we view the evaluation of low-value care. This is a study done by Ganguly in Boston. It looked at Medicare data from the United States for a period of 2 years or a year and a half, and studied cataract surgery without known heart disease, patients with undergoing cataract surgery without known heart disease. And they looked at evidence of low-value care, which was people receiving their cardiogram under those circumstances. The cost of ECG for the country was around $3.2 million, and that was 11% of the 12,000 people who received an EKG were viewed as having low-value care. And $3 million would not be very much, except when they looked at the downstream effects of the cardiogram in terms of testing and different evaluations, it came out to be $35 million. So that what's called the cascade effect is a tenfold increase in the cost of services based on the initiation of one service which may have not been necessary. So for these people that were viewed as having unnecessary cardiogram, the downstream effects were about 10%, or 10-fold increase of $35 million. So as we're looking at the consequences of low-value care for those that are entering into contracts in an ACO environment or in a capitated world, the cost may be much greater than anticipated. I want to talk to you about the elements of a successful program. First, it seems obvious, but the senior management and the board of the organization are not bought into working on low-value services. Time is going to be spent ineffectively. And so making sure that if you're assigned this task, that your senior management and board are bought into the concept is essential. And forming an interdisciplinary team anchored in the project and its core values is important. As the medical director of an IPA for 8 years, I found that when I went and visited with practitioners, that they were particularly pleased when I reported that our organizational core values were respect, integrity, and honesty. And although they didn't necessarily believe those, that I adhere to those values, they were particularly pleased that I voiced them. And people would say, I don't think that you're treating me respectfully. I would be able to talk to them about that. If they thought that I was being dishonest, they could call me on it because I had brought it up at the beginning of our conversation. And so if your team has core values, that's particularly great. If they don't have core values that someone who's visiting with a physician can articulate, it would be essential, I think, that you develop them. The ones that, for me, are most important at this point in time are respect, transparency, and non-judgmental attitude. And those are things that you think about what medical people are chosen for, non-judgmental nature and respect are not characteristics necessarily of who gets into medical school. And that may be changing now. I think there's clearly much more interest in teamwork than there used to be. But this issue of core values is really important. The other thing I found to be essential was I wrote a paper in the Annals of Internal Medicine some years ago about what physicians like to talk about based on my experience as an IPA medical director. And physicians generally don't like talking about cost of care. They're much more interested in focusing on appropriateness. And so what I found was if I talked to practitioners about what was the right thing to do, they were much happier having a conversation about what they were doing. And so I suggested that medical leaders have to be bilingual. They have to be able to speak to CFOs about economics and practitioners about appropriateness. And so I want to encourage people to think about focusing on appropriateness of care and doing what's right. It turns out in a fee-for-service world that doing what's right is always less expensive than what's being done. And so the focus on appropriateness lends itself well to thinking about efficiency of care. Next, as a general internist, if I was speaking with specialists about their behavior, they were much more interested in speaking with someone from their own discipline. And so recruiting clinical champions for each project is important, although not essential. I think it's very helpful if you have someone who steps forward from the same discipline, who's able to talk to practitioners about what they're doing. When I worked for NHU Massachusetts, there was a neurosurgeon who stepped forward to talk about frequency of back surgery. It was incredibly useful to have him speak with the chiefs of neurosurgery in the hospitals in Massachusetts rather than for me to have to do it by myself. Next, accurate dramatic reports that deliver a clear, respectful message are essential. I mean, it's impossible to talk about variations in care without having accurate dramatic reports, and we'll talk about that later. Next, these conversations that we have with practitioners tend to focus very quickly on defensiveness if you're being judgmental. So if someone gets the idea that you're talking to them and they've already decided that they're not doing the job, their task is to protect themselves. And they do that by being defensive. And that results in emotion and a response that is very difficult for medical leaders to accept and tolerate. The next piece are two constructive plan that deals with what I'm going to call unnecessary variation. And I use variation as an example because I think it's an important component of doing quality improvement work with practitioners. People are very interested in what others are doing, and in general have not had been afforded the option to see what others are doing. And so their assumption is that they're doing what everybody else is doing. I'll show some examples of why that's not the case. So collaboratively constructing this process is important, and having a plan that everybody can understand is critical. The feedback that we're going to talk about in terms of sharing data with practitioners is an essential piece of this process, and I'll talk to you about and show some examples of what respectful feedback would look like. I think I'm eager to have your questions and comments about that as we go through the discussion. Then some other final pieces are to communicate regularly with the project team, physicians, the sponsors, leaders of the system. Everybody should know what's going on, and it should be regularized so that people who are visited shouldn't feel that they're being singled out. They should understand that they're part of a process of improving the entire functioning of the system. And we'll talk a little bit at the end about how specialists in general look and interact tracking tools are essential to help people understand how they're changing. Regular reporting, the people reaching their targets, savings, return on investment, all of that is essential to different people in the system based on their interests. Trying to make the information both dramatic and current is really important. Practitioners don't want to hear what they did 6 months ago or a year ago. Actually, they don't really even want to hear about what they did 3 weeks ago. They want to hear what they're doing currently. So to the degree you can develop tools that help you keep the information dashboards current, and the more believable you will be and the more people will participate. Because as they change, they want to see the benefits of their change. And finally, I did a study in the mid-90s that looked at how empathic physicians were, and it turned out that we couldn't find any empathy. And I looked at praise in addition to empathy. We couldn't find any praise either. So I tried to think about why physicians were unable to praise patients, even though there were many praise and empathic opportunities. And what I decided when I thought about it was that practitioners are held to a standard that is usually perfection, so that the only feedback they get is when they don't do what's perfect, and that is often negative feedback. So that we don't praise physicians very often, and I think that needs to be reintroduced into the culture of medical work. So either newsletter, bonuses, plaques. When I was the medical director of an IPA, I sent certificates to people congratulating them on the work that they did to be congratulated. And I was surprised when I visited their offices that they put it up on the wall. So I realized that there was a need for praise that people weren't acknowledging. And I want to encourage people to think about that. My graphic for that is this. It's always good dogs and no great dogs. No matter what you say, it's always good to be as positive as possible, given the data that exists. So this is what I think is essential. The delivery of accurate, meaningful data is critical to being able to work with practitioners about their approach to low-value care. And there need to be clear, accessible reporting tools. And I've never met a medical leader that wouldn't like that to be the totality of what they need to do, which is if they give a clear, accessible report to a practitioner, that they'll change their behavior. And in truth, it would be a nice, but it doesn't work that way. So in general, there has to be leadership at the top has to promote the problem, the approach. There have to be core values, as I mentioned earlier. There needs to be a reason that practitioners choose this particular topic to be one on which they're going to focus their attention. And then there needs to be interpersonal process where the person being spoken to is treated respectfully, non-judgmentally, and has the opportunity to improve without feeling that they're being coerced. I hope that makes sense to everybody. These are some of the reasons that people might choose to focus on a particular. It can be that they want to reduce overuse and abuse of services. Increasingly, I think that the definition of quality improvement is moving away from simple underuse of services and towards identifying both underuse and overuse as quality measures. If you don't do that, then it looks like overuse is a cost measure, and that you're asking people to save money. And that moves into the area that I think I found unhelpful for practitioners. If you define overuse as a quality measure, and people are need to justify their decision to or to not use a particular service. Self-satisfaction in delivering appropriate care is an offshoot of that. It can be public or professional recognition. I'm not a pretty big proponent of public reporting. a motivational tool if an organization decided to do it. Patient safety is another issue. If something is a low-value service, then the service provided is offering nothing to the patient. The only possibility is that the patient will either stay the same or get worse. If there's a bad outcome from a low-value service, I think that would put the community at risk. It could be financial incentives. Those are external motivators, which I'm going to try and speak against, although they can be used as an additive if the internal motivation is great. Peer recognition is very important. That's part of the benefit of comparisons between practitioners. Reducing the cost of care is important to some people, but I don't think most practitioners is the center of what they're trying to do. So trying to be clear about what you're promoting to your practitioners is important. I would argue that probably letting the practitioner decide as the community what's important to them is more important than you telling them what's important. And that has to do with motivation, which I'll talk about at the end of this talk. So why variation? I mentioned earlier that separating cost and quality results in overuse being considered cost and quality being considered underuse. And I've learned in Rochester from the business community that underuse as a sole measure of quality is unsatisfying to them because everything means that they'll be spending more money without acknowledging that there are things that are not necessary that are being done. Dr. Berwick estimated that 30% of what we do is not necessary, and so there's lots of work that needs to be done in both the underuse of care and the overuse of care. My experience, again, is that physicians respond to conversations around appropriateness. One important marker of appropriateness is this issue of explaining variation, and I'll show some examples of that in a moment. And finally, the issue of peer comparison data being central to the task of quality improvement is something near and dear to me. I've been observing how physicians act for many years, and I'm totally enamored with the concept of peer comparison data. People are so interested in how others are doing things and what they're doing and why. And if I can stimulate conversations between physicians or between practitioners about what their reasons for choosing a test or not choosing a test are, then we can have really excellent conversations about what makes sense and what doesn't make sense. The cost of care can be brought into that, but only to the extent that the choices that are offered are considered appropriate. And anytime that I'm talking to practitioners, I say, if you think I'm asking you to do something that is not appropriate, you should call me on it, because I would never want to do that. I think that level of trust and collaboration is essential to people working with me. This is my sense of variation. There's clinical variation everywhere. Some of it is warranted. Warranted variation is a particular individual within a specialty is doing something that's different than everybody else. And I think that is in Rochester, there's one person that does most surgery. If I'm comparing his treatment of skin cancer with all the other dermatologists in town, he's different. It's considered acceptable because what he does is different. We had 3,500 practitioners in our IPA. When I asked people whose practices were different, everybody raised their hand. When I asked them who was different and you couldn't vote for yourself, they all picked the people who were different. So as a strategy, I would encourage you to say to people, if you vote for your perspective, because we want to keep those people separate, utilization of the service that's not necessary. If you have low utilization that is necessary, it's underused. And you can use variation to address either of those types of concerns. The amount of variation that exists is gap. So one question is, why is there so much variation? This is a study that was done in Boston Children's Hospital, and they asked cardiac and you can see that the vast majority of the decisions were made by experience, instinct, and what they were trained. It was very infrequent for specific studies was the reason that they chose to make their decisions. So it's not surprising that there's lots of variations in care. And that results in the ability for people to have excellent conversations. And this is an example of why underuse by itself is not sufficient. This is investigation of the relationship between cost and quality of taking care of high blood pressure. So this is the cost per episode, a year's worth of care for high blood pressure, and the control rate at that time set at 140/90 for the population that it existed. So if a practice had 80% success, which we thought was quite good, it could cost between $350 a case and $700 a case. And so trying to understand the difference between a $350 80% success rate and a $700 80% success rate seems worthwhile. I think as data becomes more available, we'll be asking practitioners not just to achieve an 80% success rate, but to look at what the costs of care are and to determine, is it necessary to use the tools and medications and testing that's required in a $700 or a $600 or a $500 practice when there are ways of getting there much cheaper. And I think looking at multiple ways to get to the right outcome is increasingly valuable. So I want to talk specifically about how you work with practitioners. The first thing is to review the organization's core values. I talked about that already. And say to people, the reason I'm sitting down with you is because we're interested in doing this project. The project is focusing on X, Y, or Z. And our core values in doing the project are honesty, respect, and integrity, or transparency, respect, and honesty. If you feel I'm not treating you based on those core values, here's my boss's phone number you can call. And I did that repeatedly. People were really excited that I talked about it. And they'd say, I don't think you're being honest. And I'd say, well, tell me what you think I'm being not honest about. And they would make up all kinds of things that they projected onto me about what I was doing. There was a lot of people were glad to know that I thought and that I was guided by these principles. Then you show them the variation data. And that's all that you do. It's generally, for me, it's been one page. It shows them to others. And then in general, these kind of information, they're not sure they know what it means. They're not sure that the reports need to be straightforward and simple. I'll get to later. But the variation data they need to think about. So I show them the data, and then I ask them, after they've had a few moments to think about it, what their thoughts are. And then they can guide me in their thinking about what's going on. Initially, often people will say, I don't trust the data. I don't believe that the methodology was correct. I think the attribution was inappropriate. And when they start asking those questions, you can start to share with them what you're trying to accomplish, what you're trying to do. In general, for me, most of the time, I wasn't here to think about what their indications for procedure were. Ask them to give themselves what oftentimes I found that I asked them to change and change their behavior. Remember, that's really important. Showing them their practices results, individual results is in general, I'm going to show as an individual result. And most of the time, because the practice, if you give results, people say it's the other people in the practice that are responsible for the variations in care. And then you have to sit back and listen to people. And that's not something that we're very good at as medical leaders. The stages of change is an important factor. I'm going to talk about that in a second. If you're dealing with a practice, you should always have, as much as possible, the individual results. If the N is too small to evaluate individuals, in general, the individuals ask me for their results anyway, even though they know the numbers aren't true. And the reason for that is I tend not to use the evaluation as a tool against them. I ask them to think about what their pattern was and what their indications for a procedure were. And if I could change the discussion away from their having to defend themselves, and defensiveness is an important sign of failure, have them think about why they're doing their test and why it's different than others, I was much more successful. When I talk to groups of medical leaders about their difficulties with talking with practitioners, basically they want the practitioner to be unemotional in the face of seeing data that suggests that they're not doing something correctly. And so when I try and help them figure out what they can do, they always try not to confront emotion. So that the necessary thing to do in a situation where someone is feeling put upon is to say to them, you seem something. You seem angry, you seem distressed, you seem upset. And invariably they say, I am. And then if you say, why are you, what's making you angry? They'll tell you what gives you insight into their feelings. Usually it's not that they're angry at you. It's usually that they're just angry. And they're angry about the fact that they're being evaluated. They're angry about the fact that they're overworked. They're angry at the fact that people have to pay for parking where they work. And I encourage you to think of this as a metaphor. I'm going to use the table metaphor as an example. If you're working with somebody and you feel that they're putting you on the same side of the table as the problem that you're addressing, then everything they tell you is made up. And your job is to get on their side of the table. The way you do that is by identifying and confronting emotions. If you can say, why are you angry? And they can tell you why they're angry, you can say, let's work on that together and see if we can figure out a way of working on it. It's incredibly valuable. It's not very hard to do, but it means that the person talking with the practitioner can't feel defensive when the person expresses emotion. And that is very hard for us to learn to do. The other thing is to avoid judgmental language, which gets you into the problem in the first place. If you call people an outlier, they have to defend themselves. If you say that you're there to promote remediation, they have to defend themselves. If you say that they had a poor outcome, they have to defend themselves because their life is spent trying to do the right thing. And so, in general, most practitioners get defensive when they judge. And that's why being non-judgmental is such an important factor. So Elizabeth Kubler-Ross defines that stages of change She called it the stages of death, and I think death is a pretty big change. But in general, what I found in my work is that people were in denial, and that medical leaders in working with practitioners would like to go from denial to bargaining, but it doesn't work that way. And in order to get there, you have to go through some either agitation, anger, or rage, and people will be emotional. And if you ask them why they're emotional, and they tell you, then you start to work at breaking through the anger and emotion. And that's the beginning of success. So I think everybody has to remember that in our ITA, we taught our staff to identify the stage of change that people were in. If someone was in denial, then we had to treat them a certain way. If someone was angry, we had to treat them a different way. If somebody was starting to bargain, then we could treat them yet another way. And trying to treat everyone as if they're trying to bargain is a mistake, because people need to have their emotions dealt with. So this is a typical variation chart. This happens to be gastroenterologist in Massachusetts. You can see that variation exists. This was the amount of scoping that was done for people with reflux esophagitis. The reason I showed it is a typical variation chart. But the arrow is focusing on one group that is in the middle of the chart. And because everybody says that they practice similarly, we wanted to look at the difference in performance for the members of that group. And you can see that the variation within the group is as great as the variation between groups. And that's why I counsel everybody to not use practices as the level of measurement, but to use the individual practitioner. This is another chart that was from Massachusetts that looked at orthopedic and neurosurgeons who operated on backs. You can see that some people operated on 5% of the people they saw, and some people operated on not 80% of the people they saw. And asking why that is an important question to share with the practitioner. And people will have lots of answers if you get them to start talking about why they think they're in a different place than others. Then they're starting to think about their indications. They can talk with others about what their indications are. And then you can ask people what the right thing to do is. And if you're focusing on the right thing, people are having conversations that are important and useful to them. This is an example of somebody asking a question about safety net practice, and assuming that safety net practices all work nothing well. So we picked the 10 practices that have the highest percentage of safety net patients in their practice, and looked at and you can see that as is the case for most things, there's wide variation in similar groups. And in this case, the groups at the bottom were interested in knowing what the groups at the top were doing. And it anchors an outcome being, if you have people competing for what percentage they are compared to their peers, and you choose the top 25% to give a bonus, and you're asking the people with the top 25% not to share what they're doing with the bottom 25%. If you pick a percent, we chose 85% as our target, and said everybody above that gets a bonus or a prize, and at least everybody's encouraged to have their partners and peers and colleagues do better. I hope that makes sense to people. I'd be happy to entertain questions. Okay. Let me just do system reports, and then I'm going to try and finish relatively quickly. The attributes of a successful report. The method is clear. It's presented simply. The indications and relative contraindications are spelled out, so you're already starting the discussion about what is indicated and what's not indicated. There's a person to contact if they have questions, and a phone number. And the feedback is delivered using respectful, non-judgmental language. I'm going to show you an example of that. Like I said, you show the report only. Your comparison is compelling. Recommendations is important. if you bring lots of drill down data, then we know that you've already judged them. And so it's better to wait for someone to ask for information than it is for you to dazzle them with how great you are at bringing the information. Stress that again. Ask for information, but you bring it without them asking for it. And you can debate that if you like, but I think it's really important to remember. The purpose of the visit is to initiate reflection. And that's defensiveness. And they were focusing on emergency room visits. They showed the comparison with your average from here, was very clear what the message is, and then they showed what is going on. You can see that about emergency room visits in general, they're talking about preventable emergency room visits. And then the medical group is a word that is used that doesn't come up very often in medical work. It's a medical category, the name of a person, contact number. There's lots of information that the group thought this was enough. And somebody was particularly effective and working in our collaborative. This is the Smarter Care Virginia program that we're doing now. And the service appropriate when it's a service not appropriate. There's going to be contact information for people to talk to people and be able to compare yourself with your colleagues in the system and give you comparative data. What will this mean for specialists? This is becoming a team sport. And so quality of care is many of the projects that I work on have been specialty projects, and the specialists will take issue with the PCPs for the way they refer. And in my discussion with them, I would say, isn't it nice to look at how you interact with it? Identifying the most common referrals will become much more important as capitation is, which I believe will be the case. And specialists will become cost centers rather than revenue generating centers, which is very different than it is now. Accepting change and the focus on volume and improving patient outcomes is tied to avoiding overuse and underuse. We call it that is self-important. This is an example of doing a project in update that second imaging versus stress echoes. The tests were judged relatively equivalent by the American College of Cardiology, and we pointed out to the different regions of the state what their comparative rankings were. You can see that the change in behavior was dramatic for this particular, the light blue community, but everybody changed as they saw data about which test they were choosing. And one of the cardiology groups reported that the hospital they were working at had figured out that SPECT imaging was much less expensive. So they fired the person, they fired the person who did stress echoes and only SPECT imaging as a like. That's uncommon, but there's lots of conversations like that that feed into our work. I'm going to end by design in a theory called internal motivation is competence, which is asking someone to do something that's possible. Autonomy, which means you discover how to solve a problem rather than be told what to do. And I think that one of the classic example of that means that you're overlooking a chance to help this relatedness, which is doing something that's meaningful. And if you give people the chance to solve problems that they think are solvable, that they get a chance to design how the solution is constructed and help them feel that they're part of a community, I think people will be internally motivated to solve the problem. Internal motivation means that rather than try and solve the problem because of money or some other external motivator, that they do it because they think it's the right thing to do. And so when the project ends, they keep doing the behavior because they have internalized it. And that's a benefit of internal motivation. If you're interested in learning more about internal motivation, this is a phenomenal YouTube video, about 8 minutes, and I strongly suggest you try. So, this is, I hope that you learn on especially with data, requires clinical leadership, the articulation of core values, an organizational commitment to the culture of improvement, and respectful involvement of the practitioner community. Data is available to do this now. We can come up with improved clinical outcomes and eliminate low-value services easily as people are motivated. Higher cost does not correlate with higher quality, so keeping track of what is low-value care is really important. And clinical measurement should focus on appropriateness of care. There is no excuse for asking people not to do things that are right things to do, and there's plenty of work to be done in that domain. So with that, I'll stop and see if you have any questions. I look forward to talking with you.
Great. This is Lisa Letourneau again. Thank you so much, Howard. We really appreciate sharing your experience and really thoughtful analysis of how to approach some of these issues. I really love your focus on recognizing the emotional response. It's not something we necessarily hear a lot about, you know, when we're talking about addressing variations in practice patterns and care. So that was really interesting from my perspective. But let's pause for a minute and see if we have any questions. I'm not seeing any questions directly in the chat, but let's just open up the
I believe
line.
Kate said that there's a question that was chatted directly to her. Kate, do you mind unmuting yourself and reading the question? Kate, you're on mute. Or you can message me the question. I will let everyone know if they would like to ask their questions aloud. There is a red microphone right next to your name, and you can click that. And Kate has sent me the question. Any thoughts on Medicare paying for transport services to non-ER EDs, but to urgent aid or PCP locations?
Well, these are questions that involve what the payment system is capitated or not. In a system where the rules are determined externally, you have to accede to the rules. In situations where you're controlling the dollars, and then if you contract or if they can decide if they think that it is worth it, they think services that would otherwise not be offered. This has to do, I think, the question is with social determinants of health, and how you pay for that is complicated. It's very difficult to provide the Medicare that to pay for. I know some years ago, the Cal Medical Foundation determined that wellness was more important than anything else in the longevity of the people, of participants. And so it started doing gardening clubs, book groups, and other things to make people feel less lonely. So the whole idea of capitated care means it gives freedom to the medical groups to try and determine what they would rather pay for. I think that, and it suggests why I think care as a they're always fighting with the payer to extend, and they always see it as more. So it's a real problem. Great question.
This is Lisa Hart. I lost a little bit. It's been a little bit in and out, but that. Howard, this is Lisa. I was just saying, you know, it's been a little bit in and out, but I lost that probably the last at least sentence or two. I don't think it's just me, so you might just want to repeat that last bit.
Oh, it's why I think capitated contracts gives the practitioner community much more flexibility in what they decide to do. I know that when I was working with the Rochester business community, every time we save money, it says that's safe, but in the long run, it always costs us more. And so I think the way that we'll get to make decisions is by taking the risk, and that's not the decision, but it's the decision to take. I think that's one of the reasons that working with variation is valuable. Well, now you can choose measures that are modest and get good at learning how to create communities where we'll talk and work together without making big losses for a system because you're getting an overuse that would have a tremendous impact on the bottom line. I don't know if that makes sense to people.
Great. Okay. Other questions, comments?
I was going to say that in Virginia, most of the people didn't ask questions because they were not yet talking with practitioners about low value services. As these experiences, I hope that people will save some of these notes and go back to them over time. My sense is that they were developed over a good 20 years of feedback from the practitioners about what worked for them. But there's a lot of other things.
Okay. Well, with that, unless, whoops. Anything else? Okay. Well, with that, looks like we're pretty close to the end of the hour, and I will turn it back to Kelly.
Thanks so much. Thank you, Dr. Beckman, for this great conversation. I do think you're right that there's a lot that keeps people from having these types of conversations, but you've given some wonderful tips today, and we will be sharing the slides on Workplace and also the recording of this on Workplace. If you don't have access to Workplace, we're happy to sign you up for it, but we also are happy to send you the slides and the recording separately if you're not interested in Workplace. I'd like to just thank everybody for joining today. I hope you'll share the webinar broadly, since I know that it's probably easier in these times to watch when we have a moment down. So thank you, Dr. Beckman, thank you, Dr. Letourneau, and thank you for everyone who showed up today. If you can take a moment, we'd love for you to evaluate the webinar at the end of this a survey will pop up, and it's only 2 questions. So stay safe, everybody, and thank you for joining us today.
Great, thank you. Thanks again.